Hi, Noreen Womack. I'm a pediatrician with the St. Luke's Children's School Mobile Clinic in Nampa and Boise.
And I'm Gretchen Gudmundsen. I'm a child clinical psychologist at St. Luke's Children's in Boise. And I'll go ahead and get started.
Yes, sorry, I couldn't unmute myself. Go ahead.
Okay, perfect. First off, thank you for the invitation to join this group today. I'm excited to be presenting with Noreen on this important topic. You can go ahead and shift to the next slide. So our goals today are just to talk a little bit about how to best understand when anxiety shifts from kind of a moment or a symptom to a more formal diagnosis that might suggest pursuing professional care or, some sort of something other than just reassurance or a distraction. We'll talk about the different types of anxiety as well as related disorders. We'll also talk about evidence-based treatments for anxiety disorders, as well as more sort of flexible skills or things to try, things to consider in the school setting, of course, and also how to coach not only kids, but staff and families, and how to be thinking of things. We'll offer some resources for nurses and families. And as Jocelyn said, we're hoping to leave sufficient time for kind of discussion and questions, but I'm welcome interruption along the way if that feels like clarification sooner rather than later would be helpful. And I'll try to keep an eye on a chat. But again, we want this to be as useful as possible. Can go ahead to the next slide. So anxiety in youth, I always work with adolescents and youth in lots of different settings, and words or symptoms or disorders that sometimes we might, all of us, minimize or dismiss, and it's really awful. So I think sometimes people, especially people who struggle with anxiety, might come into a situation and sort of minimize or just have some embarrassment or feel like, oh, it's nothing. And it really can be a really challenging disorder, even for any individuals who experience it. What's nice, and again, I'm a psychologist, so really am more well-versed in therapies and behavioral interventions, although I'm often partnering with prescribers, and really often, a combined approach is really helpful. But one of the things that is most exciting to me about anxiety is we treat it really well. So there are a lot of mental health disorders that we can struggle to intervene with, or it might only work for some people, but really we do a pretty good job with anxiety, which is why, again, I'm glad that we're sharing today, because there are a lot of sometimes counterintuitive things to do for kids who are struggling with anxiety that once you kind of know it and can see it, really can help. So again, anxiety, often when I'm kind of assessing it in a child, I sort of will throw out a lot of different words because it's a pretty broad umbrella. So it can be fear, worry, stress, nervousness, restlessness. And certainly I think as a human being, we all know what this might feel like. And it can be a little tricky to discern when does it shift from a temporary reaction to something that you might start to think about, I wonder if this kid needs to talk to their pediatrician about this or potentially pursue therapy. And really, and this is true of kind of any behavioral issue, it's when you really start to see it impairing functioning and interfering with whatever should be happening. So in kids, it's things like going to school, making friends, being able to sleep, get along with your family. As you move throughout life, it might be more like if it's impairing your ability to work, if it's straining, like, say, a marriage, partnership, that kind of thing. So anxiety tends to be persistent. It can feel really out of control and overwhelming. And it kind of is an excessive, irrational dread of everyday situations. And again, you want to be sort of tuning into whether anxiety is interfering with daily activities, even things like self-care, hygiene, eating, sleeping, age-appropriate functioning. And that's when it would be time, if that's going on for a week or two and not going away wholly, you want to start to think there might be a disorder here. So anxiety is the most common mental health diagnosis across ages and including youth. And so about at any given time, about 5 to 10% of youth, school-aged youth, will have an anxiety disorder. And if you sort of stretch that out and look over the course of childhood, 15 to 20% of youth will meet criteria for an anxiety disorder. It's really common for youth to have more than one disorder. So often when I'm in an interview, an assessment interview with a kid, I might, kind of really be candid about our diagnostic system is not perfect. Human beings are messy. So again, it might be that kids meet criteria for multiple disorders or have symptoms that straddle disorders, and that's quite likely the problem of the diagnostic system and not necessarily that the kid is so complex, but sometimes, it can go any which way. Then you do see sort of a gender difference in terms of anxiety. So females or girls have a tiny bit higher incidence of anxiety in childhood. And then when you hit puberty, that starts to become even more pronounced, with females tending to have higher rates of anxiety. And that persists through adulthood. So you can go to the next slide, please. So this is, sorry, little print, but these are the most common DSM or diagnoses of anxiety. So, and again, I wanted to just sort of highlight what it might look like, kind of typical ages. So separation anxiety is, you might, as a parent, have heard of that stage. There's a stage in early childhood when, between 18 months and 3 years old, when it's kind of a typical developmental stage to have difficulty separating from a family member. That's really typical. It's part, again, of just being a human being, and it might take longer to calm down or get settled in a daycare setting, or say going to a different caregiver. But when you see it older than age 3, and again, it's most common in ages 7 to 9, that can start to become what's called separation anxiety disorder. It might be in the school setting, you don't see that as much, because really, if it is something that is pretty incapacitating, it might result in a kid not being able to go to school. Certainly in the past few years, I think the up and downside of the pandemic and the kind of more numerous options for people to engage in education, whether it's online education or alternative settings, has possibly led to fewer kids going to the more typical elementary school setting. But again, a little initial hiccup when you transition to kindergarten is one thing, but it really is, you get to the point where they might not be able to tolerate school. We'll start to get into this, but again, with separation anxiety, it's not being able to separate. And this is where anxiety, in addition to that fear, worry, distress, nervousness, it could look more like a temper tantrum, like maybe anger, irritability, sassing at a teacher. So it isn't always, sometimes anxiety can suggest sort of a meek, kind of quiet, scared presentation, which sometimes it does, but it can also show up in a lot of different ways. And especially with kids, a little bit more in boys, sometimes it looks like irritability or anger. Selective mutism is a kind of another sort of a next disorder that is a way anxiety might manifest, most common around age 5. It's not a coincidence that it's around kindergarten age. So you might have a kid who's completely fine and verbal at home with friends in the neighborhood, and then may struggle to speak, to verbally engage with potentially like teachers. Sometimes it might be peers. And it can be really confounding for parents, because they're like, whoa, they're not like this at home or at church. Like, they can talk, whatever it is, but it can, again, be really impactful. And again, depending on your school setting, the teacher, it can really shape how that goes. And so that, again, if you're seeing a kid who really will not verbally engage at school, and it can persist. I worked with a kid who was 16 years old and had selective mutism, so it can persist beyond the early years. But there are treatments for this. It can be really, again, really treatable. And let's see, specific phobias. I think that's sometimes what people think of with anxiety. So it could be heights, storms, animals, but an avoidance of feared situations. And again, a fear of snakes may not really impact your life, but if, say, a fear of dogs means you won't go outside, you won't go to other people's houses, you maybe don't even want to walk to school because you might see a dog, something like that would warrant treatment. Social anxiety disorder is really common, and it starts to perk up in early adolescence, which part of that is that dysfunction. That's a time in life where you're starting to shift from your parents being the end all be all in your world to like peers having more power and wanting to connect more with peers. And so social anxiety disorder is this intense fear of either like social, like how you're being evaluated by friends or potentially teachers or coaches, and or performance things. So not being able to do a class presentation, not ordering your own food, just types of things that you're just not able to tolerate, which then again messes with your kind of healthy development. One thing that can sometimes there can be overlap with being sort of shy and reserved or having that temperament, but it can also be sometimes people are really quite socially skilled and sometimes feel like you don't have social anxiety or might judge or doubt that, but sometimes people might appear really socially comfortable and are in fact either avoiding things and or not functioning in a way that they would if they didn't have this disorder. Generalized anxiety disorder is that I always get at this with, again, if I'm meeting with a kid, I'm like, are you a worrier? And it's just someone who just is prone to worry. It has a very similar biological underpinning as depression, but you also have the temperament of maybe being a little restless and jumpy. You might worry about the past, the future, what you said, what you did. It just is sort of like your brain is sort of really prone to worry. And again, it can be really, some of the key symptoms are like muscle tension, messed up sleep, difficulty concentrating, fatigue. It has a pretty global impact. And finally, I'm just going to touch on panic disorder. So that's, it's more common in early adulthood, but it can happen in adolescence. So that's when typically you have sort of a sudden, unclear, like don't really know why, but you have a panic attack. You feel like you're losing control or going crazy. Sometimes you might be tuning into certain physiological things, like you think you're having a stroke or a heart attack, but you sometimes worry you're going to die. And then once you have one, you're at risk for having more, because then that has sort of you're having an experience that you fear is going to repeat. And as you can imagine, then that might lead to avoiding certain situations or similar triggers to prevent that from happening, because again, it is pretty miserable. So let's go ahead to the next slide. So one things that are not technically anxiety disorders, but really have a lot of similarities and sometimes are can be mistaken for them. So obsessive compulsive disorder, I think it's in a separate category. Part of why I like to mention it is it's often really difficult to recognize. I think sometimes we have sort of some media representations of what OCD is related to like maybe checking or like light switches or things like that. But it can sometimes, even a lot of mental health professionals might miss it. So it can be an unwanted and intrusive thoughts that sometimes are just the obsessions and then compulsions are acting on those thoughts. It can be anything from like certain numbers to germs to even things related to like really distressing thoughts, like I've known of kids who have like had violent thoughts. They might be pacifists and have never harmed a fly, and yet they have thoughts. And sometimes that's led to kind of, understandable, like a risk assessment or them getting expelled or certain things. That's actually an OCD driver, but that might be a whole other talk. And there's post-traumatic stress disorder. So another thing is that that this is and part of why I like to call these out is these each have sort of specialized treatment. So if you get any hint or question about presence of OCD or PTSD, that would potentially you'd want to work with a specialist. So you'd want to get them into their pediatrician, and we'll talk about how to access services, because trauma can also show up in a lot of different ways. And if you may or may not know, of course, the trauma history or the life history of your kids, but trauma can, show up as anger. It can show up as hypervigilance, fear, anxiety, a lot of avoidance of experiences, people, places that remind them of past traumas. But if you're sort of aware of that, that sometimes warrants a particular kind of treatment. As I already mentioned, depression has a very similar biological or genetic basis as generalized anxiety and a lot of types of anxiety, but it's a loss of kind of energy, difficulty with sleep, eating, joy, low mood. Sometimes it's irritability more than sadness, hopelessness. But these are all things that kind of can tend to cluster together. And in addition, to kids often meeting criteria for more than one disorder, it could be more than one anxiety disorder or some of these other disorders. So they can kind of go together. Let's go to the next slide. So one thing I want to shift a little bit to some of the treatments and the evidence base we have. Again, imagining that if you are, wanting to kind of guide your kids and students and families, if you are seeing hints or are aware from like an IEP evaluation or other type of evaluation that a kid has an anxiety disorder, cognitive behavioral therapy has the most robust evidence for anxiety and other disorders as well. And the thing that we'll talk a little bit about with anxiety is a behavioral approach really hinges on supporting kids to approach and do the things that are causing them fear. And the CBT is a way to structure that, to really understand that process for them, and then do sort of a graded hierarchy of how do I start to do the thing that I'm fearing the most. And if you kind of start to get exposure to it, whether it's first imagining it or talking about it, that can like make the anxiety subside or kind of become boring, and eventually you figure out, how do I do things in the face of kind of fear or anxiety. And so if you're trying to coach or refer kids to a therapist, or it might be that you refer them to their pediatrician, who then helps them get the therapy, you really want someone who's skilled in exposure, because it's not uncommon to see kids who are maybe even in therapy and it's supportive, but then they might get their avoidance and anxiety. There's a risk for it getting reinforced or almost like getting grown in a way, because you're potentially, a lot of anxious kids are really sweet and you just want them to feel better. So you might sort of, with the best of intention, people sometimes reinforce that, oh, you're going to be okay, there's nothing to be afraid of, and like reinforcing their avoidance of it, of whatever the thing is. And the kind of art of it is to figure out what exactly is driving the fear and avoidance. But this has some like details again about what it might look like. One interesting thing I think about cognitive behavioral therapy for anxiety for kids is there's even evidence. You want parents to be involved, parents and families if possible. And that's why it's cool as a school nurse or teachers, school staff, coaching kids to be brave and to try things as best they can is really important. So kids whose parents do an anxiety CBT group, the kids don't even go to the clinic. There's data that show their anxiety can get better if parents learn and model and kind of coach their kids. So there's a lot that adults in kids' lives can do when in the context of anxiety. So we can go to the next slide, which I already kind of covered some of this, so I won't belabor this. But again, the evidence base for anxiety treatment is doing exposure, so doing things that cause them to interact with that fear. Adults in kids' lives can model being brave, or maybe narrate situations where they might be nervous or fearful or worried about something and they do it anyway. Treatment should involve parents and families, whatever possible. It'll include education, and I'll let Dr. Womack talk about this more about how and when you might consider medication, because sometimes behavioral interventions are more effective when medication's on board. And it's always important to understand kind of the pros and cons of medication. As I already said, some of the places that you really want specialized treatment is if you have any reason to think a kid has OCD, PTSD, or a trauma component. If substance use is really looming large, eating disorders, or suicidality or self-harm. And so those are all really kind of more symptoms or concerns that you want someone who has expertise in that specifically whenever possible. Go ahead to the next slide. All right, and I'm going to hand the mic to Noreen.
Thank you. So actually, the only thing I'm going to mention about medication, and I'll just go ahead and talk about it now, is that typically in most situations, if somebody has a diagnosis of anxiety disorder, we definitely go to counseling first. In very rare situations, do we not do that? And then if counseling doesn't seem to be, we give it some time because, as Dr. Gudmundsen mentioned, CBT is self-limited. If close to the end of that time, really not seeing much help, and maybe they need medication to help make the therapy successful, then we consider adding medication. So that's just a word on that. So now we're going to shift to talking about some cases that I've seen in the school clinics over the last semester. I've definitely tweaked details on these students so that they are de-identified. So our first case is a 13-year-old female who visited the school nurse very frequently for shortness of breath and chest tightness. Seemed to happen more often when she made the basketball team and was doing practices. She also has a history of functional abdominal pain and had many visits to the GI doc, and actually that had completely resolved, so that was not an issue this semester. And this really astute school nurse noticed that when she would come into the school nurse office and sit there and say, I'm having difficulty breathing, my chest is tight, the vital signs would be all normal. And even after resting, there was no resolution of symptoms. And she's like, I wonder if this is an anxiety attack, and actually practiced square breathing or box breathing with her. And it seemed to really help. So that was when we got the referral to our clinic. And then next, please. So this patient was ultimately diagnosed with anxiety disorder, and it seemed like her main source of worry at the time was worry that she was going to let her team down because of her poor basketball performance. There was a lot of education in this case because the family really thought they were going to get a diagnosis of asthma and then an inhaler would make this all better. But then we went down this road instead. And so just a lot of guidance and listening and education were necessary to get this student the help she needed. Next slide. Next case was a 15-year-old female who, again, always at the school nurse's office, mainly for nausea and abdominal pain. She didn't have any absences, but definitely left school early, many, many days. She was an English language learner, not a great historian, very poor eye contact, really quiet. And then when we had the conversation with mom, a couple of things that were concerning. One was that she had been doing online classes for some time, and that this semester was the very first semester that she had attended in-person classes. And then the other thing that was worrisome is that she had significant weight loss this semester. Her body mass index went from the 31st percentile to the 3rd percentile. So she was about average height and weighed only 89 pounds. Even though she said she liked going to school, that doesn't mean it wasn't stressful, and that she didn't worry about, making sure she got from one class to another on time without being tardy, that she didn't worry about, who she'd sit with in the cafeteria, her grades, etc. So she was actually referred to the St. Luke's Adolescent Clinic, which was formerly called the Eating Disorder Clinic. And they have a multidisciplinary team there. So she started counseling there. And then our last follow-up with her recently was great. She really has developed good rapport with this counselor and has even already gained some weight. And her original initial complaints of nausea and abdominal pain were thought to be due to poor eating. So constipation, abdominal pain from constipation, and then nausea from being hungry all the time. Next slide, please. So this case was a 10-year-old male who was referred to us because of temper issues, anger issues. He was actually suspended right before we saw him because he punched the wall at school after another student was teasing him and made him really angry. He did actually have to go to the ER because he sustained a boxer's fracture or metacarpal fracture after punching the wall, which was pretty unfortunate because his family didn't have insurance. As you know, it's not cheap to go to the emergency department. He also had a history of chronic abdominal pain that was not relieved with antacids. And, we were interested to finally meet him, and we did. He was surprisingly a lovely young man, very articulate, kind of entertaining, very forthcoming. He readily admitted that he was irritable all the time and just spontaneously told us, hey, love video games, and I get to play video games all the time, and I play 8 hours every day, which I was thinking, how do you fit that in with school? But anyway, he lives with his grandmother. He was the victim of physical abuse by his parents, so he lives with grandma, who he said is his favorite person in the world, which I thought was kind of cute. So after seeing him a few times, he ended up with a diagnosis of childhood trauma, anxiety, and I didn't put in here, but also depression. He did not have a diagnosis of ADHD or attention deficit and hyperactivity disorder or oppositional defiant disorder, which is, I think, where, looking at his IEP notes, where the school was thinking his diagnosis would fall. But again, like Dr. Gudmundsen mentioned, especially in boys, you can present differently with anxiety and depression instead of having the typical, what people consider typical sadness or anxiety and worry. They might just present with irritable mood and anger outbursts. And I have one more case. I don't have a slide for this because we just saw him yesterday. We saw an adolescent who had missed 29 days of school just this semester. And when the school nurse talked to the mom, she said it was because he has a history of chest pain. He had actually been to the ER in August for chest pain, had a bit of a cardiac workup, including an echo and EKG, which were normal, but continued to have chest pain, and mom would let him stay home. When we saw him yesterday, long story short, this young man had a lot of worry about something happening to his mother. And his mother was healthy. There's nothing wrong with her. So really no basis for the worry, except he and his mom had immigrated from Colombia about a year ago. And basically she is the only constant in his life. There's a stepdad that he doesn't necessarily get along with. His biological dad is still in Colombia. And so his sleep was very poor, just worrying about his mom. And she just couldn't get him up in the morning. So again, just some re-education, reassurance about the non-organic cause of his chest pain, and then, trying to get him, hopefully we'll be able to get him to go to school a little more often. Next slide.
Noreen, could I just interject a comment about that? That's interesting. And it just kind of reminds me too, and like I might entertain a separation anxiety disorder diagnosis for him, and that makes me think one thing I didn't say was that separation anxiety, it's, there's the way our system works, it goes on the kid, but really it's that parent kid dyad and often it can come from a really valid, understandable situation like that, where you don't want to separate, there's concern, even if it's kind of it really would be safe for him to separate from mom, but that can happen a lot with separation anxiety. And again, when it's not whatever's in your head of the default notion of what that might look like, it can be a little tricky, but often, and sometimes a kid might kind of have it or have the dysfunction associated with it, but it might be even more of the parent. I'm not saying that for this kid necessarily, but it can be a parent thing of having trouble separating. And whether it's implicit or explicit messages that fall on the kid or kids.
Yeah, absolutely. The mom, allows him to stay home. She does work. She actually has two jobs, but she does allow him to stay home, and I think it does definitely go both ways with the mother and the son. That she feels the same way. I'm sure about him. That he's one of her anchors too. So yeah, 100%. I'll keep that in mind when I see him next. So, just so you guys have sightline into how we come about the diagnosis of anxiety disorder and other mental health disorders, this is one of our screening tools. This is the GAD-7, the Generalized Anxiety Disorder Screen. And there are 7 questions, and they're listed right there. And they include, as you can see, feeling nervous, not being able to stop or control worrying. I do want to point out 2 of them. One is number 5, which is being so restless that it is hard to sit still, which, as you all know, can be a core symptom of ADHD. And then number 6 is becoming easily annoyed or irritable, which can also be associated with oppositional defiant disorder. And then the other thing I wanted to point out about the screener is the last question down on the bottom. Like Dr. Gudmundsen said, it's not enough to have symptoms. You have to have functional impairment in some arena of your life, some aspect of your life. So how difficult have these symptoms made it for you to do your work, have relationships with other people and take care of things at home? And so that's a very important question that is necessary. Impairment is necessary for the diagnosis. Next slide, please. So that was a screener. This is the SCARED questionnaire. It stands for Screen for Child Anxiety Related Disorders. These are just a sample of some of the questions asked. There are actually 41 questions total in the SCARED questionnaire. There's a parent and a child version that has been validated. Am I right, Gretchen? I think all the way down to 8 years of age.
Yeah, I believe so.
And so once the questionnaire is filled out, as you can see from the gray box scoring, that it can not just help us with the diagnosis of anxiety disorder, but it can also point you in different directions for the different subsets. So panic disorder, generalized anxiety, which that's probably, I don't know, that's what I see the most commonly is generalized anxiety, separation anxiety, social anxiety, and then of course, school avoidance. Anything else you want to add to this?
Yeah, just that all of the GAD-7 and the SCARED, you can even Google them and find them for free real easily on the internet, which is nice.
And in Spanish.
Nice, even better.
Next slide, please. So as Dr. Gudmundsen again mentioned, but I just want to say again, mental and behavioral health conditions are common in children. And so what that means is you are seeing these children in your school nurse offices, and sometimes you are the very first health professional to recognize when anxiety or some other symptom is a little bit out of the normal range. Sometimes you are the one who helps identify them and get them the evaluation and management that they need. Again, don't want to belabor this point. Anxiety disorder can occur alongside many other mental health diagnoses, substance abuse, depression, ADHD, and of course, childhood trauma. And then again, the symptoms of anxiety disorder definitely overlap with other conditions. And that's part of our jobs is to try to figure out, are these co-occurring? Is one causing symptoms that look like another? That's part of what we do in our day-to-day work. And also it's important, like Dr. Gudmundsen already mentioned, anxiety, worry, stress. These are all things that can be normal, can be adaptive, and actually are helpful. Our bodies, we as human beings are equipped to handle certain amounts of stress and worry, and it can be used to our advantage. For a student, if they're worried about a big project that's coming up or a test, having that stress and worry will help you not procrastinate and not cram for the test at the last minute, or to work on that project if you're wanting a good grade. So it absolutely can be a normal response to situations. And then we have to have a higher index of suspicion for things like anxiety disorder in certain populations. For instance, LGBTQ, refugee populations, children that we know have a history of trauma, just to name a few. Next slide, please. So gonna now turn towards what things that you guys can do to help these students. You, I'm sure, see a lot of school anxiety, and there's things that you can do to help. It is absolutely within your scope of practice to teach coping and adaptation skills. Probably the first and foremost thing is to remind students and families, sometimes multiple times, that avoidance is not the answer. And again, it's so easy to just let them stay home because you're just so happy if you let them stay home, and it temporarily relieves the anxiety, but it over the long haul, the evidence shows that does not help. What helps is gradual exposure, sometimes with the help of a trained therapist. Just like the school nurse did in one of my cases, helping them practice deep breathing or other relaxation techniques can be very helpful. Positive self-talk, if you're hearing them say negative things, hey, why don't you try to reframe what you said and change the I can't do this to I can try this. Having a safe place, either being in that place or just thinking about that place, can be helpful, and your office can be that place. Often school nurses, if they have a student that's going to their office all the time, just randomly, I've heard of kids coming into a school nurse's office, 5, 6, 7 times a day, every day. I know that sometimes scheduling a check-in time, maybe even 2 check-in times, one in the morning, one in the afternoon, maybe during a passing period, so it's not disruptive to their day, can be really helpful and almost like a safety thing for those kids, so they don't have to come in as randomly. And then praising and rewarding brave behavior, seeing that kid in the hall that has a lot of absences, I'm so glad you showed up today, way to be brave, that sort of talk. Next slide. So other ways to help, a lot of times I see the school nurse being the link between the school and the family. And without belaboring the point, I know there's been a lot of controversy and talk about the Senate Bill 1329 around parental consent. But honestly, at the end of the day, that you shouldn't let that interfere with your ability to, or your just day-to-day practice of communicating with families, asking their advice, maybe offering them advice, and just really emphasizing this is a team approach. Your child is in school part of, half the day, so we want to be part of what makes the student be successful. Listening is powerful. Active listening is very therapeutic. WAIT is an acronym I heard some years ago, and it's why am I talking? And I like to remind myself of that when I'm talking to or trying to talk to an adolescent, a girl who might, be looking at her shoes and on her phone and sullen and doesn't want to talk to me. Even just it's learning to be okay with the silence in that situation, because it sends a message that I'm here and I'm listening when you're ready to talk. Practicing trauma-informed care, which I know that you guys do super well, which basically is changing the question, what's wrong with you, to what happened to you. Enlisting your school team, your vice principals, superintendents, even social work and counselors, if there's a difficult case. And then finally, since physical health and mental health are linked, just reminding kids to stay healthy and balance what they eat, drink, and do. I like the 95210 messaging because it's simple. So there's a 9 now, it's 8 to 9 hours of sleep, and 5 or more servings of fruits and veggies, 2 hours or less of screen time, 1 hour more of being active, and then limiting sugary drinks and drinking more water and milk. And I'm hoping that that's something that you've seen before. Next slide. So other ways to help students and their families deal with anxiety. It's always a safe bet to begin with a primary care provider. When you're having those conversations with a family about, let's say, like a chronic physical complaint that the child might have, that you're seeing them often in your office, have you talked to your child's regular provider about this? Might be a good idea. And oftentimes they take that advice because you are, again, the health professional in that school, the only health professional often in that school. And so your recommendation goes a long way. And then don't want to talk about screens too much, but an anxiety presentation wouldn't be complete without it, because it has been shown that inappropriate screen use, social media, can be a major source of stress and anxiety. Over the years, my two go-to websites are the American Academy of Pediatrics, and they now have a family media plan. And then the website Common Sense Media has a lot of recommendations to help parents guide their their screen plan times for their kids at home. Other online resources include mindfulness apps like Headspace or Calm. And then this is a book, What to Do When You Worry Too Much, was actually given to me by a therapist. And you can use this book. It's more of a workbook for children, even down to elementary age, to help them deal with their anxiety. It's not necessarily any way, shape, or form a substitute for counseling and or medication, but it's a helpful adjunct. And I'm sure Dr. Gudmundsen over the years has found her pet or favorite resources as well.
Yeah, I might drop some in the chat because just add to that. But Dawn Huebner is the author of this book, and she has different specific ones for different subtypes of anxiety. I feel like every couple of years. Anyway, so anything she does is excellent, and sort of different ages and types of anxiety. But I might drop some other favorites in the chat or get them to the Echo team.
Great. And then next slide. So again, if you just type into a search engine, American Academy of Pediatrics and anxiety, you're going to get a lot of web pages with parent handouts and little tips and tricks that you can do in your office. And so this is just a screenshot of one of them. Next slide.
Okay, this is the one where I'm gonna have to reshare here.
So this is a video of that I took from my Headspace app, and it's 1 minute long, and it's an example of how to practice box breathing. And hopefully Jocelyn or Kim, I'm sorry. Did this fall? Yeah. So follow the instructions. This is just a minute long video, and this is, again, an example of box breathing. Go ahead. So there are other examples. This was the breathing with waves, but there's breathing with a balloon, with a flower, with a cloud, with a cat. So something very simple that you could do easily with even all the way down to a kindergartner. And then, yeah, that's it for me. Next slide.
All right, so just want to briefly reiterate a few key points. Stress or anxiety that persists and interferes with functioning at whatever age they should be functioning is really that kind of tipping point into thinking about potentially making sure parents are aware that you are seeing some concerns, and or to recommend that they talk to their pediatrician or primary care provider about it, in addition to potentially, if they're open to it, hearing from you about ideas. And the kind of things to watch out for sometimes, again, are just, is the kid avoiding something broadly speaking. So avoidance can look like a lot of things, like it can be procrastination, it can be school absence, it can be, maybe going to the library during passing periods or lunch periods, just broadly. And avoidance, even anger can sometimes be an avoidance strategy, just like different ways to kind of not deal with often interpersonal stressors or other things that they fear, or it can look more clearly like fear. But again, as we all do, sometimes kids might self-report something, but if you kind of just be curious about stuff that may be that, or you're worried that something that a kid is doing is actually, maybe there's an underlying fear or avoidance or anxiety, that's just something to be thinking about. And it could even be like fighting or aggression that's really due to some underlying fear. But that, just things to think about, not, that's can sometimes be something that you really understand over time. But the biggest real message that I think that we started with is just that it's really treatable. So that's kind of the benefit of having your feelers out and seeing that maybe when there's a disorder, because there's some diagnoses that we really struggle to treat effectively, but anxiety is one that we have a lot of efficacy with. In general, we're wanting kids to be brave, face their fears, and also be careful as adults not to inadvertently or intentionally reinforce, helping them to escape or reassure them, like just reassure their bravery, trying things out, or making a plan to do that is really important. And I think our last slide just has some kind of key references. So there's some that we mentioned in the talk, but it's sort of a mix of the website. So the American Academy of Pediatrics, also this Anxiety Depression Association of America is a specific clinical resource, but it has info for parents, teachers, professionals about anxiety and depression. Certainly the Surgeon General has been really vocal about not only anxiety, but loneliness and social media, and just how our current society shapes some of these concerns. I also included a couple of academic papers that really, if you wanted to really dig in about kind of where the literature stands on both on the treatment of anxiety, but also a little bit more on child and adolescent, but also kind of collateral problems. So those are the two kind of more recent, up-to-date papers on that. So we have a little bit of time for questions. I don't know or I'll hand it to Jocelyn to guide us.
Yes, of course. If you have questions, feel free to unmute, or you can type those in the chat. We do have about 5 minutes left, so I'm ready for questions. I see Lisa is trying to unmute. We can't hear you. Oh, there you go.
A question. We have quite a few kids with pretty significant separation anxiety. Like they didn't have it at one point, and then all of a sudden they're just, for no reason that we can figure out, are just really struggling to say goodbye to mom when they go into school or come back from a doctor's appointment. Just wondered, as a school nurse, what is the best way to do first aid for that and help them do that separation?
What ages?
Second, third grade.
Okay.
Maybe even first grade.
I might
take first pass.
Yeah, sure. As I would think about really taking a moment to just be curious, be like, hey, I noticed this. What's going on? And they may or may not have anything to share about it. But then to figure out, like, literally, I'll have like a stair step worksheet, like try and figure out what would feel okay. Like maybe like at their next doctor appointment, would they be able to, is it come back for 5 minutes, or would it be, can they come back the next day? Like almost like get a baseline sense of like, what are you doing now? And it, almost regardless of why it's happening now, like if they share that might be helpful, but then figure out where might they just be willing to start. And almost like if a 10 is off the charts, no way, no how, I'm not doing that. 0 is, oh yeah, I can do that. Maybe like at a 1 or 2, could they tolerate or commit to a plan to like, okay, well, I'll go to recess, but that's it, or something like that, like kind of enlist them and like, what's the smallest next step they might be willing to try in terms of like starting to like do those bite-sized chunks of whatever it is that they're like afraid of or avoiding or that kind of thing.
And it's kind of nice that they've had successful attendance in the past, right? And actually this happened to one of my kids completely out of the blue. Don't even know what the trigger was. He was fine. And then it was weeks, if not months, of just having to do gradual re-exposure. And we racked our brains, what happened? Was it a nightmare? Was it a show or a comment somebody made? Or we never figured it out, but we knew we could be successful. And you can tell us to the family because they've been doing it before, they've been going to school successfully, so we can get there again. And then two, just again, that reinforcement of avoidance does not help. We need to start at this baseline and then do gradual re-exposure. And then like Dr. Gudmundsen said, give the student or the family some control over how it happens, but it has to happen, right? But just how quickly it happens can with your help be somewhat up to them, so there's a little bit of control. But yeah, it just happens. I don't understand why either, but there's lots of hope in that case for sure.
So maybe
Thank you. I think, Catherine, you might have one more question. Before I let you ask that, in case anyone has to log off, because we only have a couple minutes left, our next presentation will be on considerations for students with concussions or concussive-like symptoms. So actually, that's not even the right title. Anyway, it's about concussions. So please join us on January 8th, the same time. This will be presented by Christy Pardue at St. Luke's Sports Medicine Concussion Clinic. So I hope to see you next time. Catherine, I'll let you ask
really
a question.
quick.
Yeah.
So I'm a registered nurse in a middle school for West Ada School District. Just curious, I have a couple of students that I just want to know if clinically, if you think this is appropriate. I have a couple kids that their avoidance is if I can throw up, then I get to go home, right? If my anxiety is so bad that I throw up, then you're going to call my mom and I get to go home. And I've turned into, okay, here's a safe place to throw up, get it done, and then let's go back to class. Clinically, like just as people who have a lot more information on this than I do, is that an appropriate way to address it where I don't give it the credit that they think that vomiting gets them and just say, okay, it happened. Do you feel okay? Or are you going to do it again? If so, you got 5 minutes and then let's go back, but not giving it that, I guess, power to dictate how their day goes. Is that an appropriate treatment response?
So short answer is yes.
Okay.
agree.
There are just kids that can throw up at will, just like there's kids who can burp at will. It's just, yeah. And if it's obvious that they're doing that as a ploy versus like, you obviously don't want to miss some kid with, severe reflux or whatever, but usually you can tell as an RN if that's going on or not. And if they're perfectly fine before and they're perfectly fine after and there's nothing else, then absolutely.
Yeah.
Like
and that captures the spirit of it perfectly, because it's like, again, to have a different reaction would be understandable, and yet it would inadvertently reinforce it, right? And it is even like, they might force it or fake it, but sometimes whether it's throwing up or other things can just start to get reinforced, and then it more easily happens. And so it's really actually can be really good just to neutrally be like, oh yeah, okay, back to class.
Okay.
Not gonna.
I mean, I sent him home the first couple of times, and then after that, then you just, you develop a pattern and you see a habit, and then it's always the same class or classes. Then it's just like, okay, I'm not going to give this the credit that you really want it to have, and I'm going to downplay it. And barring obviously true fever, then we're just going to treat this like, oops, okay, let's go.
Have you talked to the family about it and gotten their buy-in?
Yeah, I see one girl probably 4 times a day. So yeah. Her mom and I, we chat a lot.
Awesome.
But, okay. Just wanted to make sure I wasn't like doing anything like detrimental by not acknowledging it, because I can't keep sending them home. So
no, you should, neutral to ignoring is how you should, because it's a behavior they want a particular response, and if you don't give it to them, it should get better over time.
Okay.
Might change.
And I feel like people, school nurses and other people, like you also, your smile, your presence, your attention is reinforcing, and you can't totally withhold that from kids, which is sort of like that tricky balance. And yet but you can also do little subtle things of like not giving them a hot shot, not like
Sure.
doing all the things. And for an eighth grader, what's reinforcing might be different. It might be getting to go home, or it might, whatever it is. But like always, you can always just remember, oh, I have this, as a person, have a reinforcing quality that I want to be careful and or strategic about if I can. Sometimes you can't, but.
Great. Cool. Thank you so much.
Thank you, everyone.